Delighted that you're all here. I think we have 30 faculty involved in this event, and they're all very keen to talk to you, to meet you, and to develop the new relationships and to tell you what they're working on. So today we have a slightly different format from last time. Those of you who came last time, I think many of you did come a couple of years ago. Based on the feedback we got, you have a choice of 2 different breakout sessions this afternoon. So I hope you all do that. We have a reception at the very end, and I'll be there to answer any more questions you may have based on what you've heard during the afternoon. And another change today, we have a keynote speaker, Dr. Elliot Sigal, one of my heroes, who I'm extremely interested to hear what he has to say about his view of cancer research from the pharmaceutical industry. So to introduce Elliot, another of my heroes, Sue, our Chancellor, Sue Desmond-Hellmann. Take it away, Sue.
I'm going to come up here. Thanks, Frank. Welcome, everyone. I'm so glad to see all of you here. And I specifically wanted to welcome you to the second now annual showcase for all of what goes on in cancer at UCSF. So first I need to brag a little bit about Frank. So you all know that UCSF is a top institution for cancer research and care. But what you might not know is that one of the most important organizations in the world for cancer, the American Association of Cancer Research, the oldest and largest scientific organization in the world, has elected as president Frank McCormick. So let's give him a round of applause. And I think that's really just helps me tell you that he has a national and international reputation as a leader. And of course, that leadership in cancer isn't something new for us at UCSF. The National Cancer Institute has once again this year renewed our recognition as a comprehensive cancer center. And I want to read to you what that means, because I actually think this is really meaningful to have that designation. What being a comprehensive cancer center means is that we've demonstrated depth and breadth of research activities in each of 3 major areas: laboratory, clinical, and population-based research, with substantial transdisciplinary research that bridges these scientific areas. An NCI-designated comprehensive cancer center must also demonstrate professional and public education and dissemination of clinical and public health advances into the community it serves. So we have to be great, and that greatness has to actually matter. It has to go out to people. And so that status has been awarded to just 7 other cancer centers in the state of California and 41 nationwide. So UCSF deserves this recognition through a lot of extraordinary accomplishments. And let me just mention a couple. In 1989, 2 UCSF scientists, Harold Varmus and my predecessor as Chancellor, Michael Bishop, earned the Nobel Prize for discovering proto-oncogenes, showing normal cellular genes could be converted to cancer genes. And in 2009, another UCSF researcher, Elizabeth Blackburn, won her Nobel for discovery of telomerase, an enzyme that plays a key role in normal cell function, but is also very important in cell aging and in cancer. And way back in 1976, a little biotech company you might have heard of, Genentech, was established by UCSF investigator Herb Boyer and is now the nation's #1 producer of cancer therapeutics. So UCSF continues to strive for leadership in cancer, and I am so delighted today to welcome a friend of UCSF and a friend of mine, Dr. Elliott Sigal. Elliot and I were reminiscing, and I have to tell you before I introduce Elliot that one of my rotations as an intern at UCSF in 1982 was at the Cancer Research Institute, where I learned how to take care of patients with cancer as a brand new doctor. So I was what you call an R1, a first-year resident. My second-year resident on the Cancer Research Institute was Dr. Elliott Sigal. So he helped teach me how to care for cancer patients. So he is now, he's gone leaps and bounds beyond. He's Chief Scientific Officer and President of R&D for Bristol-Myers Squibb. He was appointed executive vice president of the company in 2006, and he's been a member of the company's senior management team since 2001, and was appointed a member of the Bristol-Myers Squibb board of directors in March of 2011. And what's really important for you to know, and why I'm so excited that he's here to talk to us today, is he has completely transformed in his 15 years at Bristol-Myers how the company thinks about their role in bringing science to the marketplace as a biopharmaceutical company. He's increased R&D productivity, he's acquired external innovation, and he's helped to develop the company's strategy in biologics. Under Dr. Siegal's leadership, 13 new medicines have come to market to treat conditions including schizophrenia, bipolar disorder, HIV/AIDS, colon cancer, hepatitis B, and many others. He has more than 25 years of combined experience in medicine, research, and management. And he goes back to the company Syntex that many of you may have heard about, and at one point was at the genomics firm Mercator Genetics as vice president of R&D and later as CEO. And he provided the research leadership that led to the discovery of the gene for hemochromatosis, a common disorder that leads to iron overload. Dr. Siegal received his MD from University of Chicago and trained in internal medicine and pulmonary medicine here at UCSF. He received his research training at the Cardiovascular Research Institute here at UCSF and served on our faculty from '88 to '92. And before entering medical school, he studied engineering and management at Purdue University, where he received a BS, MS, and PhD. Holy cow! And he still looks so young. So please join me in a warm welcome for Dr. Elliott Sigal.
That's very nice of you. Wow. Any questions? I'm so honored to be back at UCSF. I am an alumnus of the medical resident training program. Some of my mentors are here. I'd like to thank you, Susan, for those kind remarks. And thank you, Frank and Susan, for your inspiring and important leadership of cancer research here at UCSF. And it's really important for me to be able to address so many people that support cancer research at this great institution. I took a slightly unusual path to medicine, as you might have heard towards the end. And I first, a different approach than when I drove out here with my wife in 1981 from Chicago to be an intern. From the time I was 12, my father was a PhD organic chemist, had urged me to go into engineering. In part as a reaction, I think, to my mother's family, because his brothers-in-law were all physicians, and the PhDs and MDs didn't get along in those days. I know that's changed. I was 17 when my father died of cancer. I remember my brother and me sitting at his bedside, and he asked us both a question about what we were going to do in life, and asked us why we hadn't considered medicine. And my brother and I just about fell off our chair, because the unintentional consequences that a parent has on a child sometimes last forever. And that's helped me think about raising my children. But I went on as a good son to Purdue University to study engineering. And I actually went through every course that he wrote out for me in the future. My brother went on to be a PhD in organic chemistry. He actually did research at Merck, and he opened up the field of protease inhibition for HIV/AIDS, which has helped lead to a control of that lethal disease. But by the time I was 24, my mother passed away from breast cancer. And at that point, I started to ask, why not devote my career to research in some way? I applied to the University School of Medicine at Chicago. And medicine for me was a way to give back. And my training at UCSF after medical school put me on the right track for that journey. I learned from extraordinary physicians like Dr. Holly Smith how important the history of medical advances is, and how we should always remember the context of what we do in that setting and in that history. And Dr. Jay Nadell encouraged me to collaborate with UCSF biochemists to apply molecular research to lung disease, then a field that was just evolving. So I treated patients, but I also started thinking about how research could contribute to potentially expanding the impact I could make. And for the last 20 years, I've had the privilege of a career in pharmaceutical research, and I've had the privilege to work in several of the areas that Sue mentioned. I feel a connection to the patients of the future. What I'd like to talk about is what the industry over the last several years, many years, has contributed to the field of oncology research, and hope that that's an added perspective to what you're going to hear today from basic researchers. And I want you to keep in mind, as I go through a couple of different highlights of areas, that we live in an ecosystem of contribution in the biomedical enterprise. Small companies, large companies, government funding, and very important academic researchers. And without any one piston of the engine firing, things will fail. So let me start out by talking about major advances in oncology drug therapy overall. Improvements in innovation in both detection, prevention, and treatment have provided real gains against cancers over the last few decades. And overall, age-adjusted 5-year survival rates in the US have increased by more than a third since 1975. What's more, it's been estimated that advances in drug therapy, pharmaceuticals, accounted for half or more of the increases in the survival rates. Oncology, of course, remains an area of significant unmet need, one that has been proven to be challenging, even in the face of sustained research efforts. But I think we all need to appreciate that even the incremental advances we're seeing in this field add up to very important impacts of improvement, and certain types of cancers have indeed been cured. For example, our evolving understanding of tumor biology, specifically of the blood flow around tumors, tumor angiogenesis, led to the advent of inhibitors like Avastin. What we are now calling targeted therapies on these drugs that have been introduced over this time period means very specific blockade of proteins like discrete enzymes or receptors on cells that are key to a malignant process. This type of targeting to a specific part of the process can spare normal cells and increase efficacy and safety in the clinic. This approach has greatly increased survival in diseases such as chronic myeloid leukemia with the advent of both Gleevec and Sprycel, kinase inhibitors specific to the fundamental genetic flaw in that disease. You also see here the emergence of personalized medicine, or more aptly called precision medicine, all new and promising approaches to further advancing cancer therapy. For example, Herceptin for breast cancer was one of the first examples of precision medicine where it was recognized that if the breast cancer patient expressed HER2 in the cancer, that there would be a reasonable likelihood of response to the antibody that attacked that cellular protein. Erbitux is indicated for use in colorectal cancer, where tumors, but it seems to work only where tumors have a wild type KRAS gene. Patients that have a mutated KRAS gene should not be given the medicine. Zelboraf works in patients with BRAF mutation positive metastatic melanoma and has no effect on patients without that genetic abnormality. And most recently, Xalkori was approved for the use of patients, only 5% of lung cancer patients, but those 5% of lung cancer patients have a very specific defect in the gene for a kinase called ALK. And finally, there has been the emergence of what's known as immuno-oncology, where we are harnessing the patient's own immune system to attack invading malignant cells. And I'm going to say a little bit more about that and give some patient studies and stories in a minute. Even as you see the growth of therapies at the top half of this chart in very novel areas, we continue to see more traditional therapies here on the bottom half. Overall, the continuous innovations have changed the course of cancer treatment for many patients. Roughly 30% of the pharmaceutical dollar in R&D is now spent on cancer. tens of billions of dollars annually in funding coming from the private sector, biotech and pharma, and I'm confident there should be more breakthroughs in the coming decade. Before I leave the slide, I'd like to acknowledge Sue's contribution to Herceptin, rituximab, and Avastin, and Frank's to Nexivar, as well as the fact that he gave the idea to the field that KRAS mutation could guide the therapy of colorectal cancer and the use of Erbitux. As we look ahead, there are many areas of potential innovation. I'd like to highlight three. First, the explosion of genomic information that we have now about tumors. It's leading to the changes in the way we think about and classify tumors and how we approach the patient with a given genomic profile. At the same time, through this research, the number of validated targets that we have a high confidence might actually prove to have a clinical benefit in clinical studies is increasing. And increasingly, we're using this genetic information to select the right drug for the right patient. In addition, we're becoming more precise at targeting traditional chemotherapy, cytotoxics that had the disadvantage of killing normal cells as well as cancer cells, by coupling them with antibodies and allowing the antibodies to hone in on certain types of cells within the body that are specific for that patient's cancer and deliver a payload of a traditional but highly potent chemotherapeutic agent. And as I said, most excitingly, we are now learning how to harness an individual's immune system to take advantage of natural mechanisms that the patient has developed to fight foreign attacks and to attack tumors in this case. Let me first focus on how the explosion of genomics information is shaping the way we think about cancer therapeutics. Historically, of course, tumors have been named based on their anatomical site of origin. In the past, we diagnosed patients with lung cancer, colon cancer, prostate cancer, but the explosion of genomics information about tumors means tumor types are being increasingly defined not only by anatomical site of origin or histology under the microscope, but also by the genes and proteins that they express. The NCI has sponsored the Cancer Genome Atlas. It's a research pilot funded also with the National Human Genome Research Institute to catalog genetic mutations responsible in human cancers. Papers are now coming out that describe the molecular similarities between various tumor types regardless of their anatomical origin. On the left, tumors are color-coded by the type of organ that they come from, as you can see, and on the right by their genomic profile, which could be a set of expressed genes or genetic mutations. By analyzing the genetic makeup of a tumor and measuring drug response, we expect to be able to treat with a targeted medicine a subtype of, say, lung cancer, represented as red on the right, for example. And some of these lung cancers may respond to drug therapy more like a select set of colon cancers, also shown partly in red, or some prostate cancers, rather than other types of lung cancers. Such a paradigm offers us in clinic the chance of improved efficacy to our patients and potentially more uses for medicines that have already been developed. We're now seeing people screen our libraries or our marketed medicines against genetic targets that might be relevant to different cancers and start with an approved drug and expand its known indications. Obviously, relating a tumor to a genetic signature is one step towards validating research along a given biochemical pathway. Hence, I believe the pipeline of new drugs in the industry is perhaps more validated than at any other time in history. However, target validation is a complex subject and is still an area of intense research. The concept of tailoring treatment to a patient's individual situation using a diagnostic or predictive biomarker or some clinical assessment, of course, is not new. That's basic good medicine. Physicians have always sought to understand the cause of an individual's patient disease, their subset of that disease, and treat accordingly. However, what has changed in the last several years is the rapid advancement of science technology, and of the understanding of diseases at the molecular level. By gaining more knowledge and insight into the biology of disease processes, scientists and physicians are beginning to understand some of the underlying variability of how patients respond to the same drug treatment. And by identifying biomarkers that are associated with better results, we can select patients who are most likely to benefit from that therapy. In this example, you see on the left an all-comer population where it's coded the patients that will ultimately benefit from the therapy. In blue or in orange will not benefit from the therapy. After a genetic test is performed, as represented by the color-coded array there, patients can be stratified with those most likely to respond having a 75% benefit after being pre-selected versus the earlier all-comer 45%. And then you save about 40% of the patients from being exposed to potentially toxic medicine where you think there is no potential benefit. As I mentioned earlier, Frank McCormick suggested many years ago, actually to me personally, that therapies that targeted the EGFR pathway, such as Erbitux in colon cancer, would not work in patients who have a mutation in the gene for KRAS. And today, patients are screened once the diagnosis is made for colon cancer. And if they have a certain KRAS status, you know that patient should receive the benefit of Erbitux, and otherwise, that biologic is not considered appropriate for that patient. UCSF is doing much work in this area. For example, a team led by Sarah Nelson has developed methods to reveal a molecular marker in tissue sampled from brain tumors that has been linked to better survival odds. And the implications for targeted medicine in general are far-reaching, not only in clinical practice, but in my world of drug development. Obviously, if you have the opportunity to test a drug in a subset with a higher likelihood of response, you could theoretically have a smaller clinical program and a faster clinical program and reduce the fact that the noise introduced by non-selection causes you to miss a new therapy altogether. The second topic I'd like to talk about is the development of antibody-directed cytotoxics. It's another good example of innovation in cancer research. That's not a new idea. We've been working on this for 20 or 30 years or more. There have been ups and downs in this area, much like in the area of antibody-delivered therapeutics in general. But the limitation of cytotoxics or classic chemotherapy is that they kill normal cells, and we'd like to target them better. The antibody conjugate platform is based on the idea that if you can attach the active ingredient, the cytotoxic or chemotherapeutic agent, to a linker, and that linker is a chemical that has a lot of important properties and can attach to an antibody, you can use the homing mechanism of the antibody to be very, very specific, and the nature of the chemistry to release the cytotoxic agent only when necessary and only when effective. Each element of an antibody-directed conjugate has to work exactly right if the goal is to be achieved. And it's been working out this chemistry that has been difficult. The antibody-drug conjugate bring a cytotoxic payload, as I mentioned, to tumor cells and even sometimes in the cancer cell by aiming at a particular antigen shown here of a cancer cell, and specifically a tumor surface antigen that may be specific to that tumor and specific, of course, to the antibody. And it's possible, if the chemistry is right, the biochemistry is right, that the linker can release the cytotoxic agent just by being proximal to the right cell. And in some cases, the linkage to the antigen, which is normally internalized, allows the cytotoxic agent to go right into the cell where you want it, and then the biochemistry releases through the linker the specific medicine. So as the chemical reaction takes place, the targeted delivery of the classical chemotherapy is achieved and the cancer cell is killed, and hopefully the approach is with better efficacy and better safety than classic chemotherapy. This has been a long haul in research. Genentech is at the lead with something under review at the regulatory authorities now for breast cancer. But the platform is quite generalizable, using other antibodies to direct to other tumors and to maximizing the efficiency of the linker and the chemotherapeutic agent. So many companies are active in that area. The third topic and final topic I'd like to introduce you to or say something about is an area we've been very active in and that we call immuno-oncology. This is a rather straightforward concept. And I think and when I read this recently in preparing for this talk, I thought of Holly, who always drew something from history to show that no idea was totally new, but in the context of medicine, very enlightening and very encouraging. So for actually hundreds of years, people had made the clinical observation, and when patients developed an infection and had cancer, sometimes the tumor totally regressed. And in fact, Bill Coley in New York about 100 years ago, after losing a patient to sarcoma, began administering different bacterial antigens to induce such a fever, an infection, and observe some series of regression. And that's where the field stayed for a long time. But clearly, the thought of eliciting an immune-based response that the body might naturally be capable of delivering that could be anti-tumorigenic remained on the table for about 100 years. And people have tried different elements of the immune system to administer. The use of immunotherapy, in our experience, yields a different type of response by the very nature of the mechanism. We're used to delivering an agent and watching the tumor shrink. But in this case, you incite an inflammatory reaction and the tumor swells. And in fact, many of our competitors missed this scientific fact and thought it was actually progression of the disease. And we pursued it further. Once the immune system is reactivated, the responses to fight tumors can be quite profound and quite durable, as I'll show you. Unfortunately, it's not a large percentage of patients that get affected, but it's an important start. 20 to 30% of the patients are now responding to a newly marketed drug that's an immuno-oncology agent with 4 and 5 years survival, and in some cases, no evidence of disease. In a situation, metastatic melanoma, that is usually fatal within a year. So I'd like to take a moment to explain a little bit about the mechanism. Antigen-presenting cells, some type of foreign matter, even matter from a cancer cell, in the body is naturally, an antigen is naturally presented to part of the immune system, a T cell. And with a complicated signaling mechanism, that T cell can be activated, it can proliferate, and it can fight the recognizable cell from which the antigen came, in this case a tumor. That leads to cancer cell death and potentially control of the tumor. But cancer cells are very smart, and they're actually able to produce a protein that shuts the system off. And so the therapy, one therapeutic approach, is to remove that brake and allow the immune system to do its job. And that was the thought of an academic researcher at Berkeley, Dr. Allison. It was the work initially of both some scientists at a biotech company that Bristol-Myers had bought many, many years ago, and a biotech company that's down the road in Redwood City that we also had to buy later. And I'm glad we did. Let me explain multiple approaches and then give you the clinical result of a phase 3 study and a patient or two experience. The interaction between the tumor antigen and the T cell is necessary, but not sufficient to activate the T cell and to allow proliferation. A second co-stimulatory pathway between proteins that are called CD28 on the T cell and the complex of CD80 and CD86 on the antigen-presenting cell is an interaction that's required, along with the T cell receptor interacting with the tumor antigen as presented by the antigen-presenting cell. A natural brake, as I mentioned, exists. And after this activation, T cells start to put on its cell surface another protein called CTLA4. And that protein competes with this interaction, displacing CD28 but not allowing activation of T cells. So basically, it's a break, and it turns off this immune reaction. We developed an antibody to CTLA-4, which cuts off that break, removes the checkpoint, and allows reactivation of the pathway along this costimulatory pathway and reactivation of the cells. And I'm going to show you some clinical results of that protein, that antibody. It's a medicine now called ipilimumab. The branded name is Yervoy. But there are other opportunities to improve upon this because some of this interaction is not as specific in certain tumors as we would like, and there are side effects of an immune reaction becoming nonspecific. Another important pathway involves PD-1 and PD-L1, and antibodies have been developed both to one side of the pathway and to the other, and disrupting this pathway also allows reactivation of the T cells. Both these molecules are in experimental studies in several companies, including Bristol-Myers Squibb, and may have the advantage of having a more targeted approach because of which tumors express either PD-L1 or PD-1. Lastly, there's another pathway that's being worked on. It goes by the name 41BB and 41BBL, and the antibody is to the CD137 protein on the T cell. Probably the best way to describe this reaction is to take an individual patient. And I'd like to mention at this point that here at UCSF, Dr. Eric Small, who I just saw in the audience, administered to the first patient ipilimumab in the year 2000. This is not his patient, and I will say these pictures are of a graphic nature, but it's a patient with metastatic melanoma that had lost all hope. Here is the back of that patient with an invading melanoma tumor. What's not seen is the fact that the same tumor was infiltrating internal organs throughout this individual at the time. And later it progressed and failed all current therapy. When he was, the patient began the anti-CTLA-4 medicine that I'll call ipilimumab after failing all current therapies. And when he was seen 12 weeks later, you can see the response that is characteristic in this situation where it looks like progression. And in some cases, the care of the patient might dictate that you would stop. In fact, new lesions would often appear. But a very important clinical scientist observed that some lesions would get worse, and there might be a mechanism for that, as I explained, and some tumors in the body would totally disappear. And so we had a cohort of patients that we continued to deliver this medicine to. And at week 14, there was evidence of improvement. At week 16, there's what we would call a durable response. But after 2 years, the patient was in total remission. And what is even more remarkable is that today the patient's in his 5th year after starting ipilimumab with no obvious evidence of disease. Most patients with metastatic melanoma, as I mentioned, die within the first year. And as I've told employees and other audiences when I've presented this case, that in the old days we would have called this a miracle. Nowadays I have to call it an anecdote. And for a long time I had the frustration of talking about many, many anecdotes until we published a study, our investigators published a study of 2 phase 3 randomized trials that have now established that a certain set of patients can actually have this benefit, and this leads to an improvement in overall survival. Here's one of the survival curves from a study of ipilimumab in first-line metastatic melanoma that's presented at a major oncology set of conferences in 2011 and 2012 and published in the New England Journal of Medicine. This is what people recognize as the Kaplan-Meier curve, a survival curve where on the vertical axis we have the proportion of the patients in the trial or in the arm of the trial that are alive at any time point, and the time is represented on the horizontal axis in months. The ipilimumab or anti-CTLA-4 therapy is represented in blue, and that line throughout is higher, meaning more people are alive at any given point than the control. And there's 2 studies, one against control and one against patients that are on DTIC or dacarbazine, which is a standard of care, which has not necessarily established a survival benefit. And the survival numbers are given here, and at 4 years, the chance of being alive are doubled. And in fact, in other studies, the chances of being alive at 1 year, 2 year, 3 year, and 4 year remain doubled. This is quite unusual for a Kaplan-Meier curve in oncology, as Sue will tell you. It's very unique. It's very unusual to see a Kaplan-Meier curve where the curves don't eventually come together. We've not seen curves come together, meaning that the drug no longer has an extended benefit. It's had a benefit up to a certain time period. This indicates that a cohort of patients are having a durable impact on their survival and may be a subset of patients that could lead to a definition of cure if that definition is no disease evidence after 5 years and then later 10 years. But the other point I'd like to make on this curve is that the numbers are too low. Although it's wonderful advance, we'd like to find a way to either target to the population that's going to respond or, more importantly, get that response rate higher. And there's evidence that combining immunotherapy with radiation that might make more antigens available for the immune response, or even traditional chemotherapy that's already approved, or other agents targeting the T cell, as I mentioned, might increase the effect and the number of patients that benefit. So we and others are busy at expanding this, but not only for melanoma. The mechanism is tumor independent, and we're studying patients with prostate cancer, ovarian cancer, and lung cancer. Here's another patient story that's less graphic, but possibly more compelling. This lady has lent me the use of her name, Sharon Belvin. More than 7 years ago, in her last year in college, she started to embark on a teaching career, and she had a cough that was diagnosed as bronchitis or asthma. She was treated with no effect, and it was her dressmaker for her wedding gown that noticed a lesion on her skin, which was worked up in the correct diagnosis of metastatic melanoma infiltrating internal organs, including the lung and the brain, were evident. And she kept getting worse, decided anyway to get married and to go on an experimental trial with anti-CTLA-4, ipilimumab, to re-engage her body's own immune system. Today, Sharon's a mother of a 4-year-old and a 2.5-year-old. She gave birth to these children after she went into remission. These pictures were taken 2 years ago. She and her husband have moved into the country where she always wanted to live, and she's in remission today. We've heard of numerous cases of other babies being born to mothers who otherwise would have clearly died. And our job now is to extend that promise of hope through new innovations to more people and to other cancers, as I mentioned. So let me conclude by saying we're living in clearly an age of wonderful science that can be translated into clinical practice. And let me go back to my initial comment that we live in an ecosystem, including government-sponsored research, academic research, and industrial research, all of which must be healthy and working on the same goal. And I think that's key to accelerating the advances out of the bench laboratories into the clinical science. A focus on partnerships to extend our reach and scope has been critical to all R&D organizations. And it's understandable for a number of reasons now more than ever before. We're in a very globally interconnected world. Science is more and more complex. Regulatory environment is very demanding, and we are all resource constrained. Research grants are very hard to come by. R&D budgets are getting smaller, and we have to share our ideas, our resources more than ever. Academia is critical to everything the industry does. This is just one piece of data that substantiates that, and you can cut this in many different ways depending on how you define where the initial discovery or the intellectual property actually came from. But of the drugs that were approved from 1998 through 2007, about a quarter of them are directly from discoveries in academia. And this could possibly go to 1/3 of all discoveries in drugs, depending on the way you define the contributions. In the past, collaborations between industry and academia have been difficult. There are intellectual property rights, contracting delays, lack of aligned incentives of an academic organization versus a for-profit commercial organization. There's been little true collaboration in some alliances that have been formed, but now I think both academia and industry recognize the value of working together to benefit their own enterprises. Part of that is economically driven. Part of it is driven by the need to be more and more creative. One of the areas that I think is very important and that I was talking to Sue about earlier is in target identification and validation. And I mentioned the Cancer Genome Atlas. We ourselves are working with UCSF in Alzheimer's disease across the street into Gladstone for new targets in Alzheimer's. The second area is candidate drug identification. Bristol-Myers Squibb, most recent example in this type of alliances is with Vanderbilt, where they've set up, and this is controversial, an in-house drug discovery group that screens targets that have been derived from their own academic researchers' research, develop drugs up to a certain point, and then look for partners. That's being done at San Diego, it's being done at Harvard, it's being done at Vanderbilt. It's controversial, but it's evident to the fact that new models are being worked out to enhance this collaboration and accelerate the science translation. Finally, a lot of work that brings industry and academia together is done in the areas of translational research. And I personally think that's the most fruitful area, because at a major medical institution, there's no better place than having bench scientists living with clinical scientists that take care of patients and translating that information. Now, there's lots of barriers to that, even within one institution, but there's no reason for other institutions to set that up. In industry, it's better to collaborate for that. And we're doing that at different places. Pfizer is here at UCSF. Pfizer is also at Washington University. Bristol-Myers Squibb is at Duke. So in closing, I'd like to leave you with one lesson I learned in my early medical training that may be relevant. I was going on rounds with an attending physician in the hem-onc wards. One morning, my professor told me to go into a patient's room to observe, come out and report what I saw. I told him that the patient I had seen was a man about 38, looked well-nourished, muscular, had a full head of hair, face full of color. His major complaint was that his gums were bleeding constantly and easily. I assumed that there was a platelet abnormality of some sort. Then I asked what the professor saw. With the matter-of-factness of an oncologist, hardened by years of probably seeing the same thing over and over again, and hardened by what was then the limited weapons at his disposal to fight the disease, the professor responded, "I see a young man who is full of a life, but who before too long will be emaciated. He will lose his hair. His complexion will turn sallow. The energy you see in his eyes will vanish. Eventually, we'll put tubes in him again and again, and see if we can stretch his life for a matter of days or weeks. I see a patient we can't treat. This man had already been diagnosed with blast phase chronic myelogenous leukemia, which in 1981 was a diagnosis of a painful death." What I learned was what may be true one day can be transformed into something entirely different the next. It may take time. Even what may seem like an eternity, but for the right minds, working on seemingly intractable problems is a challenge to change the world. Drugs such as Gleevec and Sprycel keep patients with CML living normal lives for years, perhaps decades, and that's today. We have come a long distance in understanding more about the complexity of cancer and the possibilities of helping cancer patients, but there's hard work ahead. For the rest of the day, you will hear exciting research at UCSF at the Helen Diller Cancer Center, and these people are changing the world for tomorrow, and in turn offering hope to patients. Each of us in cancer research at stellar academic institutions or at companies like mine, and in collaborations between the two, are contributing to biomedical advances. So I thank you for your support, and I hope you see, from my vantage point, what it can do one day. You are shoring up a vital link for patients of the future. Thank you very much.
Don't sit down.
Huh?
Don't go away. Elliot will be delighted to answer any questions. I know it will be fun.
I'm curious to know how, what your attitude, what Bristol-Myers' attitude is to combination trials with some of these new drugs, for example, Provention and Ipi, that involve other companies, other pharmaceutical companies, beyond Bristol-Myers, in other words, not just collaboration between you and universities, but there has to be collaboration between different pharmaceutical companies, and how feasible is that?
Yes. So it's a two-part question. How do I feel about it, and how feasible is it? I feel very strongly, and I urge this, and we are doing some of those trials. And I think it's probably unfair for us to conclude that that isn't happening or won't happen. But it is reasonable to assume that sometimes there are difficulties in doing that. In the area of cancer, and today also in the area of hepatitis C, which like HIV and cancer is requiring combination therapy, none of us want to wait to get individual drugs approved and then put them together. So we actually have alliances now more than ever before, and Merck does the same thing, Vertex is doing the same thing, both in cancer and in virology, to take experimental drugs to the extent the FDA will allow. And the FDA is encouraging this, and do experimental regimens with 2 or 3 unapproved drugs. Now, to the extent that you encourage that with marketed drugs already, which may have been the question because both ipilimumab and Provention are now both marketed, we happen to be very interested in that. Nobody's prevented from doing that study because the drugs are available. We could help it if we think the science is right and the clinical benefit is right by funding. And we do that on occasion. I don't think it's done enough. And there are competitive pressures, just like you would think of, you know, how willing is a young assistant professor willing to open up his notebook on everything to somebody else before he gets it published. There are incentive analogies everywhere, but I think we all see a better output by some collaborations. It's happening, it's being encouraged by the FDA, and I think we'll see more of it. Sue?
It's just such a beautiful set of stories you told.
Yes.
In patients with melanoma, but it would make me nervous clinically watching somebody's tumor get larger and then smaller.
It did, yeah.
So how is the progress going on figuring out both de novo who was most likely to benefit, so a biomarker that says ipilimumab's the right drug, but also who will then go on to have these prolonged remissions or even cure? Do you have any signs, any tests that you can do to predict that?
Well, we are working on that. A lot of academic researchers are working on that. And I would say the industry no longer is hoping that doesn't happen. We actually see benefits that it does happen. The people that pay for these medicines want to know who not to give the medicine to. That increases the value to the patient and to the company of where the drug is administered. So I think biomarkers, although there was a lot of psychological resistance at some point, has now become reality. But with that is the reality that science, parallel science, doesn't always develop at the same pace as the drug. And you can't necessarily support, a parallel universe of all this research since most drugs fail. So we do have, as we were talking about it over lunch, a program to try to produce a biomarker in discovery as something comes into clinic. And we have trained the whole organization to develop companion diagnostics. In this area, we couldn't find anything that was valid, and there's a lot of important science that has to be done to be sure it's valid, or you're withholding an important drug from somebody with a false negative. There are academic groups that are doing that, but one of our investigators said something very interesting to me. He said, we could spend a lot of time trying to select the patients not to give this drug to, or we could put a lot of resources in trying to increase the response rate and learning how to use this medicine, which you know very well. Once it's approved, we know probably the least about how a medicine will eventually be used. So we're trying both of that.
Just one comment on that. With my AUCR hat on, we developed a dialogue with the FDA and invited them to sort of bring in the top scientists on the planet to address that kind of issue. So we sent Jim Allison to the FDA, and he spent a day with PASDA and those guys working through all the issues of biomarkers which are perplexing them, but they are determined to solve. So I think it's encouraging that the FDA is on the right side of these issues.
The FDA has taken their time, as they should, to make sure the science is solid. They took longer than I thought they would with KRAS, for example.
It was 10 years ago, wasn't it? More than that?
Well, it was not quite, but you were there first. And it took people for a long time to prove to themselves what constitutes regulatory science to document that this should be paired. So it's complicated since all our information isn't complete. But I think it's a very exciting time, and I think all the forces are in the same direction.
The question I had was whether in the realm of immuno-oncology, is anybody here or elsewhere doing work on nutrition to either bolster those T cells that you're hoping to target the tumor with, or to, unfortunately, enhance the growth of the tumor so that it's not such a good idea to use a particular nutrient?
I'm not aware of that, but there should be some science on that.
I would think so.
Yeah, I'm not aware of that. I'll have to take that back.
Thank you, Dr. Sigal. This is very enlightening. I wanted to ask a follow-up question to Sue's, which is these anecdotes, these successful patients. Is it important to know what's going on with their molecular biology? And if so, how do you study that?
Yes. Yeah. There have been a lot of proposals, and one of the things we do at Bristol, knowing that the innovation is not just within, by any means, our four walls, is we do have investigator-sponsored research. There are a lot of immunologists proposing to us research that should be funded to study those patients. We set up an international academic industry collaboration with about 10 to 12 sites, and we're going to expand that. The people that have been associated with the ipilimumab trials, that have patients from those trials, and have immunologists at their centers that are interested in exploring what's unique about the priming of their T cell system, what's unique about the response after the drug of their immune system, what's unique about this pathway. And I presented, obviously, a cartoon of the pathway. As we learn more about patient response, that's going to be revised.
And that's kind of research that couldn't have happened until you had a sufficient number of patients with a response to actually get some sort of real meat to the problem. So
and real translation.
The field of immunotherapy in that respect, and raised a whole range of interesting questions for research. So it's extremely important.
Thank you, Frank.
This is our last question.
Oh. We're just getting warmed up.
So is ipilimumab restricted in its efficacy to melanoma, and if so, why?
I don't believe it's going to be restricted, but the only phase 3 controlled trials we have read out so far is in melanoma. We have nice anecdotes in prostate cancer. We have some responses in phase 2 studies for lung cancer. We have hope from early clinical experimentation in ovarian cancer. I do not believe it should be restricted. The idea of which cancers are immunogenic has arisen by which drugs are available and which responses we're seeing. So in the interleukin-2 days, when that was our major immunotherapy, or interferons, we classified kidney cancer and melanoma as immunogenic. I think we're going to find out that those cancers are not the only cancers responsive to immune modulation. And we have some of these studies, and others have studies, similar studies, that are going to be unfolding in the next couple of years.
Fascinating question. I think originally, many of us thought that because melanoma cells have a very high mutational load, that they may be particularly good at presenting antigens, and maybe lung cancer also, but that turns out not to be true.
Well, I don't think we know yet. I just would not limit our concept of immunogenic tumors to kidney and melanoma at this point.
Definitely, yeah, it's fantastic. Okay, apparently we're out of time for questions, so I'll...
Thank you.